Hi, I'm Dick Moberg, your host for today's presentation, and I want to welcome you all to the Brain Matters webinar series. Our topic today is the identification of spreading depolarizations in bedside ECoG with Moberg CNS. We are honored today to have our featured speaker, Dr. Jed Hardings of the University of Cincinnati College of Medicine. He'll provide a practical overview of how to record and identify spreading depolarizations in bedside ECoG recordings of brain-injured patients. We'll be going live to Dr. Hardings in just a minute. And to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. You and your colleagues can sign up anytime on our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. And I want to remind you about the Curing Coma campaign. Our friends at the Neurocritical Care Society asked if I would pass this along to you. Many of you are involved in this campaign. They want to let you know that the Come Together Coma Care Research Survey is now open. So please go to their website to take the survey. And finally, please type your questions into the Q&A tab on Zoom during the talk. We'll go to the Q&A directly after Dr. Harding's talk. And we'll now go live to beautiful downtown Cincinnati for our featured presentation.
Good afternoon. Pleasure to give another Moberg Gray Matter Series webinar. We've given some SD webinars in the past on kind of the basic biology and clinical translation, interpretation of spreading depolarization. So for this webinar, we wanted to go and dive down a little deeper with some practical recommendations. So this webinar will be a little bit of a hybrid between a seminar and a workshop, with really the aim of providing practical advice and guidance for people who are interested in actually doing this kind of monitoring. What does it look like really at the bedside? How do you review these events in real time? How do you particularly use the Moberg CNS software to review these events? So those are kind of our practical aims. And while I don't want to spend time on background of SD, I'm going to need to assume some level of familiarity with the topic. What I do just want to emphasize briefly is that while spreading depolarizations are primarily electrophysiologic events driven by the loss of ion homeostasis in tissue and in cells, and of course they're measured in electrical recordings, this disturbance is in fact so profound that it affects all aspects of cellular and tissue function. So spreading depolarizations are intensely energy depleting. There's a massive release of neurotransmitters. There are profound blood flow changes. There are changes on the cellular and molecular level, as shown here in these micrographs, electron micrographs of cytotoxic edema, also shown here in the 2-photon imaging. And even on the organelle level, there's fissure of and swelling of the mitochondria, as well as the endoplasmic reticulum. So that's just important to keep in mind when thinking about how interpreting depolarizations and why they occur, what do they mean when they occur, and what is their impact. Because their impact, as shown through decades of experimental work, seems to be that they're a required mechanism of acute neuronal lesions to develop. So these are not merely epiphenomena of how brain networks organize and different patterns of activity they can generate. This is really fundamental to the biology of nervous tissue. And just wanted to provide some resources, and the webinar in general will have a lot of detailed information, and that's because I want this to serve as a resource for people to come back to and dig into some of these details and review things if it interests them. So there's a couple videos on the YouTube Moberg Research channel, a 25-minute documentary film that I think is a very interesting introduction to the topic and how it got translated from bench to bedside, and then the prior webinar that I mentioned, as well as a few recommended review articles covering both basic science as well as clinical application. So spreading depolarizations are recorded in both animal and man with full band field potential recordings from the gray matter. The depolarization itself is measured as a slow potential change, labeled here DC, that lasts 1 to 2 minutes as it moves through the tissue, and it spreads across various points that can be measured in the gray matter, with some delay reflecting a propagation velocity of typically 3 to 5 millimeters per minute. And so this is what measures the depolarization, mass tissue depolarization itself. There's a second component that's called spreading depression. Spreading depression is reflected in the suppression of the baseline spontaneous oscillatory activity. And its onset begins with the onset of the depolarization reflected in the DC potential, also known as the slow potential. And the spreading depression is a consequence of the spreading depolarization. It's the depolarization that disrupts electrical signaling in the tissue and causes the depression. And this is measured the same way in animals as it is in man. And so just a brief review of how we place electrodes in patients. The opportunity is afforded by the requirement for an emergency craniotomy in certain types of patients with severe brain injury, either hemorrhagic stroke or traumatic brain injury, or malignant stroke for decompression. And at the time of the surgery, the decompression or lesion evacuation surgery, an electrode strip can be placed directly on the brain, subdural space, and left there in place after closure, so that when the patient is returned into the operating room, the electrode strip tail can be hooked up to a cable and plugged in directly to an EEG amplifier to make continuous recordings that can last several days up to a couple weeks. And that's been reviewed rather thoroughly elsewhere. The method that we use to make these recordings, predominantly in the United States, is to use the Moberg component neuromonitoring system, CNS, shown here at the left. And it's very simple to connect the electrode strip to the Moberg ICU, advanced ICU EEG amplifier, which is shown here at the right. This amplifier was specially designed with 8 auxiliary input channels, specifically for simultaneous intracranial recordings acquired together with the scalp montage. And it allows for a separate reference for those internal electrodes. So from the electrode strip, the cable terminates in 6 to 8 connectors, which are input into these auxiliary channels. And then a separate reference is placed into the auxiliary reference. That can either be a subdermal platinum needle electrode, or it can be a scalp sulfur chloride electrode. Both work well. And then you connect to ground and you're ready to begin the recordings. So this is a textbook example of an SD recorded in a patient using this technique. And shown are recordings from 2 electrodes from this 6 electrode subdural strip, coated in gold and blue. And you'll notice there are 2 traces shown for each electrode recording. Those traces are both, again, from the same recording. They're simply filtered in different manners to convey information about the depolarization, the DC or slow potential change, and the depression of higher frequency activity. And there's 2 main features of this recording that I want to highlight. First is the highly compressed time scale of about 45 minutes here. Typically, we view these recordings on at least a compression of 30 minutes per page. And the second is the very large amplitude of the signals into the range of millivolts. Now, contrast this to what we're used to in clinical electrophysiology, basically in EEG recordings, which is the display of data on a very expanded time scale, so that you're only looking at seconds per page rather than minutes or hours. And then also the amplitude, where activity is typically in the 100 microvolt or smaller range, as compared to 100-fold greater in the millivolt range. So to understand how these methods relate to each other, it's important to consider that brain activity contains a mixture of frequencies, just like white light is composed of various individual colors blended together. So too can brain activity be decomposed into various frequencies, from higher frequencies down to slower potentials, until we start to reach that lower limit, the theoretical limit of zero frequency, which is also known as direct current, as opposed to oscillating, alternating current. So in conventional EEG recordings, we typically filter out this low frequency activity and only record these higher frequencies. And by higher frequency here, I mean 0.1 or 0.5 hertz or higher. Whereas in order to record and measure spreading depolarizations, we need a wider bandwidth that goes all the way down to the theoretical limit of 0 hertz. So that's the bandwidth required. And to illustrate how these methods relate to each other, here we show a full band recording of 4 spreading depolarizations occurring over several hours on that large amplitude scale. And so we can look at one of these depolarizations in greater detail and see, we recognize the negative direct current shift or slow potential. But riding on top of this is this oscillating faster activity. This is the spontaneous brain activity. And you'll notice that when the negative DC shift begins is when this spontaneous brain activity becomes depressed. And even after recovery from the depolarization, it remains depressed and will stay so for several minutes or longer. We can then filter out this baseline shifting potential here in order to better see the depression period. So the baseline spontaneous activity followed by a depression and a gradual recovery. And if we then expand this still compressed time scale, we can get what typically looks like a typical EEG type of high-resolution waveform. So that's how we go from compressed scales in large amplitudes down all the way down to expanded time scales and much smaller amplitude activity. And we capture all of these in our recordings. Our colleagues at Berlin have put together a fantastic website at Brain Tsunamis at charityacademy.de. And I wanted to share a video that explains this in this very same thing, but in a slightly different way. I think it's useful to kind of hear it from 2 perspectives, because these are somewhat complex concepts for people not familiar with it. So I'd just like to play this video and encourage anyone to check out the rest of their website. It's a wonderful resource for education about spreading depolarizations.
In this video, we'll look at the difference between spreading depolarization and spreading depression in the electrocorticogram. If we want to examine the individual waveforms of spontaneous brain activity, that is, the fast-changing components of the electrocorticogram, we normally filter out the very low frequencies, and we look at an expanded timescale. Here, we're only looking at 5 seconds per frame. The amplitude of spontaneous brain activity typically lies in the range of a few hundred microvolts or less. If we zoom out of this view to a 40-minute frame, the individual waveforms of the spontaneous activity become less and less visible. Spreading depression of activity is a sudden loss of amplitude of the spontaneous activity. If we want to see the phenomenon that causes the silencing of the spontaneous activity, we have to use amplifiers that are capable of recording very low frequencies. So we want to expand our current frequency band. What we see now is a spreading depolarization, characterized by a very large negative slow potential change. Its amplitude is huge in comparison to the spontaneous brain activity, and we can see how the amplitude of the spontaneous activity becomes depressed with the onset of the depolarization. Depolarizations last several minutes, and they sometimes occur as clustered events. We can also further expand the frequency band to include frequencies all the way down to the theoretical limit of 0 Hz, which then shows us the full spectrum of wave components. The negative slow potential change indicates the mass depolarization of cells in the cerebral cortex. Looking at an individual neuron during spreading depolarization, you can see the breakdown of the physiological ion concentration gradients across its cell membrane. This results in cytotoxic edema with cellular swelling, distortion of the dendritic spines, and eventually loss of function. Therefore, spreading depression is always a consequence of spreading depolarization.
Okay. So I hope that provided helped with the understanding of how these different scales relate to each other. And with that understanding, we can now get into the display and interpretation of spreading depolarizations at the bedside using the Moberg CNS software. So this is the typical display that we use here at the University of Cincinnati. This is, again, a 6-channel referential ECoG recording from a 6-channel, 6-electrode strip. And we have 2 different displays here. On the top display is the temporally compressed data. So we're looking at, looks like about 30 minutes of data. And then in the second display, we have the same data from the same 6 electrodes shown on an expanded time scale of between 10 to 30 seconds so that we can see the individual waveforms that aren't appreciable in the compressed data display. You can, of course, sync these 2 displays so that you always know that what you're looking at on the bottom is time aligned with the cursor in the top display. And then you can navigate forward and backwards through the recording with the arrows on the touch screen. Of course, you've probably noticed that there are actually two waveform displays in the top area, and these are the 2 that correspond to filtering specific to the high frequency activity, which is shown in white, and to the slow potentials, which are shown in red. So, in order to get into those displays and change the filter and amplitude settings, what you do is simply touch on one of these channels and then click the Edit Selected. So when we do that, we are brought up with this menu, which I will now walk you through. And this is all very important to be sure that you have interpretable recordings when you begin recording from a patient and can recognize activity. So the first aspect is the time scale setting. You have options from 20 seconds up to 12 hours. We like to use 30 minutes or 1 hour. Secondly, importantly, you have these selection of wave types where you can choose to display the EEG only data or the slow potential only data or the overlap of the 2. So we've obviously selected the EEG and slow potential, which is what our custom is. There's an overlap, which refers to the overlap of the data between adjacent channels. That's going to be important as well. And then finally, there's 2 different filter and sensitivity settings separately for the higher frequency white activity and for the lower frequency slow potential red activity. And what's really important and somewhat novel here is the low filter setting for the slow potentials in order to get these displays. So I'm going to spend a little time explaining that. If we go into the low filter setting for the slow potentials, we have several options. The first is that there is no filter applied. So this is the raw DC full band waveform, including the zero frequency component, which is also known as the offset. And oftentimes there's very substantial offset in these recordings so that the actual data you're recording is outside of the display view. And an example of that is shown here, where you see this red line at the bottom, at the top, and another one at the bottom indicating that several of these channels are beyond the range of display. The other three of these 6 are just kind of floating in space, and we don't really know which one corresponds to which channel. So that's why it's necessary to use some technique to zero the recordings into your display window. And so that brings us to the second option, which is that there is still no filter, but the level, the DC level or the offset level, has been centered in the display area. And you can see that here. This is the same traces as in the previous slide, but now with DC centered. And you can see, for instance, channel 6 has this potential drifting slightly negatively, starting above and then going below the white traces, et cetera, et cetera. So this actually is a very useful setting to use. The great advantage of it is that there still is no filtering of the data, and we can directly interpret these slow potential waveforms. The third option is to use a low-pass filter, high-pass filter, that's the low-end filter, of 0.005 or 0.01. This is also often used very frequently. And what happens here is that the very lowest frequencies are filtered out in order to provide an exact centering of the traces, so that the baseline red trace is always running through the middle of the higher frequency white traces. And this makes the review very speedy and somewhat simplified. And the downside of this is that it does distort the raw DC waveforms of spreading depolarizations. So we can't directly interpret these funny-looking triphasic waves, but it doesn't filter it so much that we can't see that they're there. So that's the real advantage of this, as well as the limitation. So using these techniques, then, it's important when you begin a recording. It's always important to check your amplitude, your filter settings, and your time scales to make sure that they make sense for ECoG signals. And I'll just give you a few examples of confusing displays where you're not sure exactly what's going wrong or why this doesn't look like published data. But the fixes are all very simple. So this is an example where you've got whiteout on the screen. And this is because the EEG signals, the high frequency signals, are simply too sensitive. They're very large in amplitude on your display, and they're overlapping from one channel to the other one, causing this whiteout effect. So that's very simple to fix by decreasing the sensitivity or gain of the high frequency signals. This is another example similar to the above, but to the first one, but the same is now also true for the red or slow potential signals, where the gain is just simply too high. They're all running into each other. It needs to be decreased. The third example shows a good sensitivity settings for the high frequency white signals. They're not overlapping each other. They're taking full advantage of the space on the display, but nicely separated. The red traces, however, appear to be completely flat. They're just running through. So does that mean we're not getting any recordings? in the low frequency range or what? No, it simply means that the sensitivity setting is in a bad range, and it needs more gain. So basically, the signals are just being flattened here. We need to apply more gain to get them into view, but not so much as in the second example. So getting those things set up and playing with the gain and filtering settings is really important. So once we have all those that are display set up correctly, we can then start to look for spreading depolarizations. And there are basically 5 criteria for recognizing them. And those are as follows, as illustrated in the traces shown. The first is that there should be depression of the EEG or high frequency amplitude. Here we're using EEG as synonymous with higher frequency activity. Again, 0.5 hertz or greater. And we can see in this trace there is a depression here in the first channel. There's a depression here in the second, and in the third, and in the fourth. So we have that. Secondly, there's a slow potential change in channels that have the depression, and we see that again in each of these 4, 2, 3, 4. Thirdly, that the onset of the slow potential and the depression occur generally simultaneously, and we see that. And fourth, there should be a spread or a temporal delay of these events between adjacent channels. And so we can see that very clearly here. The onset of the slow potential here occurs with the depression, and then the same is the case here in channel 3, and there's a very clear delay of about 7 minutes between these 2 occurrences, and you can do the simple math that these are separated. These 2 electrodes are separated by 20 millimeters, and so you can use the minutes and time delay to compute 3 to 5 millimeters per minute in spread. And the same is true of channel 4 and channel 5. And so a fifth criteria that can be helpful is that the pattern of the waveforms repeats in a stereotyped fashion through multiple events. Very rarely would you have a situation where only 1 or 2 spreading depolarizations are occurring in a patient. Usually you'll get them numbering in the dozens or more. And typically they will recur in the same pattern. And what I mean by that is the same waveform on individual channels, and also the same sequence of occurrence on the different channels. So here, for instance, this patient has a very unique pattern where it first occurs on channel 5, and then 1, and then 4, and then 3. And then there's very high probability that the next one would occur in the same sequence. And so in cases where there's some uncertainty as to whether an event is real or not, if you see it repeating in that same pattern, that can help to increase your confidence. So that would be 1 SD. So looking in a little bit more closely at recognizing, well, what slow potentials really are the ones that identify spreading depolarizations, because certainly there's a lot of slow potentials in the data, many of which can merely be artifacts or could be something else. Usually they're artifacts. So some of the characteristics I've listed here of the slow potentials of SDs are that they typically have very smooth contours, and they typically have a triphasic shape. So the example here, where negative is pointing up, is a negative, positive, negative waveform, and that's typically the case. You can see it in each of these other channels too: negative, positive, negative, negative, positive, negative. And this is in contrast to very sharply contoured slow potentials that are almost always the result of artifact. So the smoothness can distinguish those, as well as the time delay and sequence, because artifacts are almost always occurring simultaneously across channels rather than having this sequential occurrence. And the amplitude here would be in the range of a few hundred microvolts to 1 or 2 millivolts. So Important. So these are the characteristics when using the 0.01 or 0.005 high pass or low end filter. When we look at the slow potentials using the DC centered display with no filtering, the characteristics change a little bit in the sense that the amplitude of the waveforms becomes much larger, now in the range of several millivolts to up to 10 to 15. And the shape also changes from a triphasic shape to a predominant single negative phase, as shown here. The second, here's another one. Other than that, it's about the same duration of a few minutes, and it should also have very smooth contours. And again, because when you change these filters, the display range is gonna, these waves are gonna be much larger with the DC centered display. You will also have to change your sensitivity settings to accommodate that. And these settings are always shown at the right, so always check those if something isn't making sense. As far as identifying the depression pattern, there's one signature that's a strong indicator of a depression caused by a spreading depolarization, as opposed to some other cause such as a change in sedation or an arousal event or something else. And that's that the depression pattern is very asymmetric, usually in the onset period compared to the recovery period, where the onset of the depression occurs over 30 to 60 seconds, but the recovery period is much longer lasting, over 5, 10, 20 minutes. So this is a very strong indicator that an event is an SD. If I saw this pattern alone with no other information, I would know with pretty much certainty that this is a spreading depolarization causing this spreading depression. Yet not all spreading depolarizations have this pattern. So this is very specific for spreading depolarizations, but it's not very sensitive for spreading depolarizations. Another variant that's really important is that spreading depolarizations can occur in tissue that doesn't have spontaneous activity. And this is one example of such an event, where you see in channels 1 through 4, the baseline brain activity is non-existent. I mean, this is flatlined, especially in comparison to looking at channels 5 and 6 that have this nice spontaneous activity in it. But we don't really necessarily know that when these channels are flat, whether that indicates the tissue is dead or merely quiescent. We don't know. It doesn't tell us that. But if the tissue is still viable, it's still capable of supporting the propagation of spreading depolarizations. And so this is one example where we can see clearly these small amplitude negative shifts in the potential that are occurring in a stereotyped repetitive pattern in connection with these verified spreading depolarization events with DC shifts and depression periods in channel 4, 5, and 6. So essentially, this is a spreading depolarization that's isoelectric in channel 4, but that causes spreading depression in channels 5 and 6. And this is another example from a different patient, where here I'm just showing the compressed higher frequency activity, where channel 1 has pretty robust baseline activity, but is interrupted by 4 depression periods that look like spreading depressions. Channels 2 through 6 are pretty flat though, so it really looks like there's not much going on here. Yet if we display the exact same recordings looking at the slow potentials, we see a very, very different picture. We see first that indeed there are negative shifts accompanying the depressions in channel 1, so these indeed are spreading depolarizations with spreading depression. But what we see now is that this activity in channels 2 through 5 is not so quiescent. Rather, there are spreading depolarizations propagating repetitively through this tissue. So we can see here, for instance, This wave starts in channel 2 and propagates to, channel 5 and propagates to 4, 3, 2, 1, and then the same pattern repeats again, 5, 4, 3, 2, 1. And so again, just to emphasize, spreading depolarization can occur without spreading depression if there's no spontaneous activity in the tissue. And that further reinforces why it's really important not to use these terms synonymously. There's one other aspect of recognizing spreading depolarizations that occurs from time to time, and that is the presence of a pulse artifact that's observed in the electrical recordings, usually during the depolarization itself in tissue that has sparse or no spontaneous activity. So typically these are identified with isoelectric spreading depolarizations. And some examples of this are shown in each of these channels 4, 5, and 6 in association with these depolarizations. So you can see 3 events spreading through the tissue here. And then you see these bands that look like little bursts of seizure activity. Sometimes they take on this bow tie shaped appearance. And when we look at these in detail on an expanded time scale, you see that they're not actually seizures. These are perfectly time locked with the ECoG or the pulse waveform. So these are some sort of artifacts. We don't know what's causing them. Could be related to some changes in the tissue, electrical resistance or vascular changes. We're not sure, but these can be very robust and aid in the identification of spreading depolarizations, particularly in isoelectric tissue. So we can also record spreading depolarizations in depth using depth electrodes, and I just wanted to touch on this briefly. The first most important point is that depth is a little bit of a misnomer for spreading depolarization monitoring, because typically these electrode arrays placed in the brain tissue are targeted towards the white matter. But spreading depolarizations are a gray matter phenomenon. You're not going to record them in white matter. So what we like to do to monitor for SD is to try to target them superficially in the brain. And we do this by trying to align the most superficial electrode on the array just with the very inner table of the bolt, so that we can be assured that one of these contacts will be placed in the outer band of gray matter. You might also sometimes get a sulcus or something on the way down with one of the deeper electrodes. But that's important to place these more superficially. And the identification of SDs in depth electrode recordings is basically the same as in subdural ECoG strip recordings. There are the 5 criteria. There's just one really that doesn't apply, and that is the spread of slow potentials and depressions between adjacent channels. And it's easy to understand why that doesn't apply, because with a depth electrode, you're essentially sampling one point in cortex, whereas with a subdural strip, you're sampling 5 centimeters and have the opportunity to see a time delay of occurrence between adjacent electrodes. That's not the case with the depth recording. So what you would typically see is something like what is shown here, where there is a depression in just one channel only, and it's associated with the negative DC shift. And here's just another example, same thing, where we're seeing a repeating stereotyped DC shift and depression in electrode 8, but not in the other channels. And of course, with this comprehensive display of data on both compressed and expanded timescales, we can of course see seizure activity along with the spreading depolarizations. Here you see it in the compressed display as this white band running across all the channels, and zoomed in, you can appreciate the repetitive spiking activity. And a question that often gets asked is, how do you distinguish SDs from seizures? well, you can appreciate now, I think, that they're nothing like each other. The seizure here is an increase of activity as opposed to a depression of activity. There's no prominent DC or slow potential change. The changes occur generally simultaneously during a seizure, whereas they propagate at a very slow velocity with a delay between channels with spreading depolarization. So they're really nothing like each other. And finally, I just wanted to highlight that these recordings can be reviewed offline as well. Everything I've been covering so far has been, using the real-time bedside display. But you can also use the Moberg CNS Envision software, as well as software from AD Instruments called LabChart for sort of more detailed review and scoring. And so I just want to share a few slides from this very interesting case to illustrate kind of how all this fits together. The observation of seizures and spreading depolarizations and how they kind of co-evolve in different patterns. And I want to do that using the Envision. This is the Envision software. No time to go through how to operate it and how to do all the settings, but you can see that the basic setup is the same here as on the bedside display on the Moberg monitor. The only difference here being that the white and black colors have been changed. So the white's in the background. So in this first screenshot, you can see that there are seizures occurring at about every 15-minute intervals in these first two channels of a subdural ECoG strip. The other four channels have relatively normal, consistent activity patterns. And these seizures, here you can see them on a expanded time scale with repetitive spiking. And of course, we can also acquire simultaneous scalp EEG recordings. And you can see here in the left hemisphere where the strip is located, these seizures are observable only in the ECoG and not on the scalp. After an hour or two of these seizures every 15 minutes, we then observe a spreading depolarization occurring in this channel 2 and spreading to channel 3. And what's interesting is that just before this SD begins in channel 2, in that same channel, we start to see the evolution of periodic discharges. And so then the SD occurs, the brain activity is silenced, and then it starts to recover, but it recovers to a much more severe pattern of continuous periodic discharges, and only in this channel. And here you can see what those discharges look like, recurring with a pseudo-periodicity of 5 to 7 seconds or so, repetitive spiking. These periodic discharges then continue in channel 2, and they're interrupted by further spreading depolarizations, again propagating with the same pattern. This is another example of the stereotyped pattern that helps us recognize these events, going from channel 2 to 3. And there's some other interesting aspects of this recording here as well, because now we're seeing periodic discharges in channel 2, a spreading depolarization, and we're also seeing seizures then going across the entire electrode strip. So we see here within a period of an hour or so this full spectrum of electrophysiologic pathology. And we also notice here what looks like a seizure during the slow potential change in channel 2. But in fact, this is one of those pulse artifacts that I talked about that we often see in badly damaged tissue, which is consistent with this being the electrode that's showing the periodic discharges. And so we can see that pulse artifact occurring. And it's definitely a distinct pattern from what this seizure is showing here. Whereas this is occurring about one per second as the heartbeat, the seizure is happening much faster and has these spike components. So after some period of time, the SDs stopped in this patient, and then the entire electrode strip evolved into this prolonged status epilepticus that continued for hours, as shown here. And at this point, they had, in fact, generalized to being able to be seen from the scalp EEG recordings, as shown here in these red traces from the left hemisphere. So that was a very interesting case, and I think helps illustrate how recording the whole bandwidth and recording things on multiple time scales with multiple filter settings can really provide a much more complete picture. And also having, of course, the intracranial ECoG strip recordings, without which most of this activity wouldn't be seen until it mysteriously appears on the scalp, as now at this point in this patient. Gives you a much greater picture of the full evolution of pathology, and further provides that early warning so that you can begin these interventions before things get too bad, as developed in this case. Final slide, and this is just to note that from the Envision software, you can also export data in the EDF format, and then import those EDF files into LabChart. So why is LabChart important? LabChart is the software that was used by the COSBID folks for 15 years to really develop this science in the very first place, before the Moberg monitor had the capacity to do these measurements. And so a lot of the recommendations, particularly in the publication from 2017, shown here, give particular suggestions for how to program the analysis of spreading depolarizations using LabChart language. So I'd like to acknowledge all of the COSBID collaborators who have helped develop this science, and hopefully we can get together soon once this COVID is passed. And I'd like to thank the DoD for providing funding for my research. And I hope that this has been useful, and that this might provide a resource for folks in the future to come back to as other centers begin contemplating adopting this type of monitoring. Thank you very much.
Thank you, Jed. That was awesome, as usual. And if you want to unshare your screen, and then there looks like there's a bunch of questions there. If you want to turn your camera on and we can see you, and that'd be cool too.
Okay, there we go. Hello, everyone. First question, is the webinar recorded? Can we have it for review later? Yes, I believe so. Correct, Dick?
That's correct. It should be up on our website by next week.
Yeah, that's good. And yeah, it was kind of cool. I got an email from someone in Italy just a couple of weeks ago who said that they had just watched the 2017 webinar and got super interested in it, and they're writing a college thesis on the topic. So very useful to have these archived and recorded. So thank you, Dick.
Sure.
Second question, when you see these in Cincinnati, are you treating them? Are you using ketamine? We aren't right now in Cincinnati because there's still really valuable research discoveries to be made from recording these. So and studying them. So we're involved in a multi-center trial where we specifically are avoiding treatments in order to collect observational data. So at this point, no. There are several sites, more in Europe than the United States, that are using these for clinical care. And ketamine is, of course, a favored treatment. Another question, what do you think is the big picture here in terms of getting SD monitoring and potentially treatment into more ICUs around the world? Great question. It's something we've grappled with and worked on a lot. The problem here is generalizability and kind of manpower methodology for bedside monitoring. So a few things that we're working on is developing a less invasive technique so that we can monitor these in patients that don't need craniotomies and for whom placement of a subdural strip isn't justified. That's important. There might be some optical or imaging techniques out there that can do this as well. But certainly a huge step forward in this has been the advanced ICU amplifier and the new software for the Moberg monitor that allow this recording in using equipment that many hospitals have. So it's a huge advance over the methods and equipment we used to use. And I would finally just add, more education is always needed. I think the consensus paper that I just referenced in my last slide was a big step for explaining how, sharing our methods and explaining to others how we've been doing this. We're definitely interested in getting more investigators, more people performing this type of monitoring to share their experience. So that's why we chose the topic as we did today as well. The practical side is really important. Next question. Is there any way to justify placing ECoG strips in patients with craniotomies not in a research setting who don't need them for EEG monitoring? Well, I mean, a lot of not in a research setting, so I would take that to mean as for clinical care, and a number of sites are doing this for clinical care. I just mentioned that we're doing it now primarily as a research for a research study, research purposes, requires patient and family consent. But if we were not in this study, we would be doing this for clinical care, as many other centers are. I think that there's overwhelming justification for the clinical utility of this, that this could be used to help guide care. Now, what is that guidance specifically? What are the particular interventions that, how can you treat the patient? Or are you just doing this for, appeasing yourself to better understand what's happening? That remains to be determined. Ketamine certainly can slow these down, but we don't know yet, and block them, but we don't know yet whether what impact that has on long-term outcomes. So prospective studies are definitely going to be needed to see how the diagnosis of these events indicates different management strategies. There's a question about any hospitals or centers doing research about SD in Latin America. None that I know of. I know that there have been some inquiries through the years. Certainly that would be just really fantastic, and that's a ripe avenue of research for someone from Latin America to spearhead. It will be particularly gratifying since Aristides Leao, who discovered these events in 1944, was from Rio de Janeiro, and it's certainly a spiritual home for people who do this kind of research. So we'd love to see it blossom there. One more question. We're approaching the end of the hour. How promising is surface or scalp EEG for SD monitoring? So far, it's very promising as a technique for patients who've had their bone flap removed, who've had the craniectomy. The skull is a very good spatial filter, and since these are such focal events, that spatial blurring imposed by the skull makes it very difficult, if not impossible, to observe spreading depolarizations in the scalp when the skull is intact. However, if the skull's been removed, there are most of the time there are very clear signatures in the scalp recorded EEG over the area of the craniectomy that identify these events. So we're currently working on better defining what those signatures are. So I think that's about it. One more question here. Besides ketamine, what about calcium channel blockers? No, I don't think so. The no individual class of drugs targeting a specific mechanism works except for NMDA receptor antagonists. Calcium channel blockers alone don't help. Almost all these patients are on Keppra, which has calcium antagonist properties, and we see plenty of spreading depolarizations. So nimodipine, I think, is a really interesting drug for its effects on to ameliorate neurovascular coupling and decrease the impact of spreading decrease the adverse impact of spreading depolarizations. So it's very interesting as a possible combination therapy to treat spreading depolarizations. So Andrew Carlson published a wonderful review on nimodipine last year and discussed some of this, maybe 2 years ago. But yeah, very interesting. So Dick, thank you a lot. I think maybe that wraps it up. I appreciate all the questions and for everyone who attended.
Well, thanks, Jed. You know, I actually have a very quick one. And I was in a hospital a couple of years ago. I won't mention which one, but they showed me some multimodal recordings, brain oxygen, metabolism, and all that. They weren't even recording EEG, and they saw these sort of periodic changes, like in the PBTO2 and stuff, and ICP. And they gave ketamine, and it flattened them right out. And so and I know they, probably a little off-label, but the question is how do these spreading depolarizations affect the things that you would normally monitor, like oxygen and everything? And I know they do. I've seen some work from your group and all that. But any comments on if you're looking at the multimodal monitoring data and you're not recording for spreading depolarizations, could the knowledge that these might be occurring help you in interpreting that data?
You're right that they can affect those variables. The problem is usually when those monitors are placed, they're not placed in such a way as to reflect the effects of spreading depolarizations, because again, for oxygen, for instance, they're placed deeper in white matter, so you're really not going to see those signatures. So as far as a typical, multimodal monitoring signature of spreading depolarizations, we don't have one. I don't think that there's any clear kind of set of changes that we say, oh, that's due to spreading depolarizations. So unfortunately, no. All the multimodal monitoring we've done with this has shown that most SDs occur when oxygen values, ICP values, CPP values tend to be in normal ranges. So it seems to be a pathology that can be independent and usually is independent of those other insults measured by those other modalities.
Got it.
But certainly if one placed an oxygen sensor in the cortex, you would see periodic dips or biphasic changes in the PBTO2 values that would be signatures of spreading depolarization, consequences of spreading depolarizations. We've certainly seen that. I know Ron Balu has been very interested in documenting that. So, yeah, thank you for that question.
Great, good. Well, let's see. I think there's did another question. Well, one more question crept in here. Maybe you can do that. We don't have to stay strictly to the hours from.
Okay.
They could do that, and then we'll wrap up after this one.
Are spreading depolarizations associated with delirium, and couldn't treating them with sedatives worsen delirium? If so, does Precedex have any effect on spreading depolarizations? I'm not aware that there's any evidence that Precedex does. And as far as an association with delirium, I'm really not so sure. I don't know that anyone has examined that specifically. So I apologize, I'd have to pretty much punt on that question.
All right, well, I guess that'll wrap it up. And I just want to say thank you so much for another very inspiring talk. And I do hope when the pandemic lifts, we'll be able to get together once again at a COSBID meeting. I know many of our listeners have been to that meeting. If you haven't, put it on your calendar as soon as you guys figure out a date for it. It's one of the best meetings I've ever attended, and it's wonderful. It's a great group of people. So I hope we can meet again. It'll be in Europe this next time, and.
Right. Currently, it was scheduled for January 8th to 10th, but I think that's going to be canceled. So stand by, and you can always go to the COSBID website to sign up to get announcements about the meetings.
Great, and we'll be publicizing it too through our newsletter.
Yep.
So once again, thank you so much, Jed, and really appreciate the time you took to put this together. It's a great resource for a lot of people.
Great.
Thank you. And thanks to all of our listeners, and especially those in Europe, a little bit late hour. I appreciate you tuning in, and we'll see you at the next webinar. Thank you all.
Great. Thank you.